Hello, and welcome to our program titled Ushering in a New Era in the Treatment of Chronic Kidney Disease and Anemia, Appreciating the Patient Burden, Exploring Pathways and Pathogenesis, Reflecting on New and Emerging Data. I'm Dr. Ajay Singh, Senior Associate Dean for Postgraduate Medical Education and Director, Master in Medical Sciences and Clinical Investigation Program at Harvard Medical School. I'm also a nephrologist at the Brigham and Women's Hospital here in Boston. I'm joined today by my esteemed colleagues, Dr. Edgar Lerma, Clinical Professor of Medicine from the University of Illinois in Chicago, Illinois, and by Dr. Jay Wish, Professor of Clinical Medicine at the Indiana School of Medicine. Dr. Wish serves as Chief Medical Officer for Outpatient Dialysis at Indiana University Health in Indianapolis, Indiana. The faculty disclosures are displayed on the screen for your convenience. This program is supported by an educational grant from GSK. We would like to thank them for support of this initiative. Our program today will include a robust presentation and panel discussion surrounding the roles of PHI-HIF in CKD anemia and the rationale for developing a therapy that targets PHI. The learning objective for this initiative is as follows. Describe the rationale of targeting PHI-HIF for the treatment of anemia in CKD. I'll now turn the presentation over to Dr. Wish, who will lead us through a brief presentation.
First, we're going to turn to the topic of hepcidin, because this plays a central role in the anemia of patients with chronic kidney disease. Hepcidin is a hormone that's produced in the liver and is the main regulator of systemic iron homeostasis. It evolved primarily to prevent iron overload because it inhibits iron absorption by the GI tract, and there's no physiologic way for the human to excrete iron other than through a phlebotomy. In addition, hepcidin sequesters iron in the setting of inflammation. And this was an evolutionary adaptation to make us more resistant to siderophilic pathogens by sequestering the iron in the reticular endothelial system and making it unavailable for the pathogen in the blood. So as you can see in the green boxes, either increases in iron or inflammation lead to the increase in hepcidin levels, which physiologically decrease iron absorption, decreasing iron recycling from senescent red cells, and also increasing the amount of iron in storage. This adversely affects erythropoiesis because of decreases in iron availability. Erythropoiesis itself, however, decreases hepcidin and increases iron availability to support the production of new red blood cells. The mechanisms underlying anemia and chronic kidney disease are summarized in this graphic slide. The black arrows represent a normal physiologic hormone in iron flux. The black arrows with a bar at the end represent normal physiologic downregulation. The blue bars represent accumulation, and the red bars represent inhibition. So as you can see, the liver normally produces hepcidin in a regulatory fashion, as we mentioned in the previous slide. This is also augmented by inflammation due to chronic kidney disease, as well as decreased renal clearance of hepcidin. The hepcidin has negative effects on iron homeostasis by preventing its release from macrophages and making it less available for red blood cell production. On the extreme right-hand side of the slide, you can see that erythropoietin is produced by the normal kidney, but in the presence of CKD progression, erythropoietin production goes down, and this also adversely affects the ability for the bone marrow to produce red blood cells. So as CKD progression increases, you have increased inflammation, reduce the renal clearance of hepcidin, and ultimately decrease levels of erythropoietin in the blood. As a result, hepcidin levels increase from the chronic inflammation and decreased renal clearance. And as we said, increased hepcidin adversely affects iron homeostasis by making it unavailable for red blood cell production in the bone marrow, resulting in anemia. Now we turn to the HIF pathway. HIF stands for hypoxia-inducible factors, and these are oxygen-sensitive proteins that were discovered around 2000 that regulate the cell's transcriptional response to hypoxia. And it's very important for tissues, cells, and the organism as a whole to respond to hypoxia so that the organism doesn't basically suffocate in the absence of availability of oxygen. The HIF pathway is the central regulator of erythropoiesis as well in response to hypoxia. There are two master HIF regulators. There is HIF beta subunit, which is present in the nucleus and is pretty much produced all the time and is available all the time. On the other hand, there is cytoplasmic HIF alpha subunit, which is oxygen dependent and is rapidly degraded in the presence of oxygen by an enzyme called HIF prolyl hydroxylase. Ultimately, if the HIF alpha survives in the presence of hypoxia, it dimerizes with beta to perform a heterodimer, which is ultimately regulated by a group of oxygen-dependent enzymes and iron-dependent enzymes, which we call these prolyl hydroxylase or prolyl hydroxylase domain enzymes, PHD. And there are actually three PHD variants, PHD1, PHD2, and PHD3, which have some subtle differences in terms of their tissue distribution, as well as their specificity for various HIF alpha subunits. Now, in this slide, you can see what happens in the presence of normoxia, or normal oxygen delivery to the tissues. If oxygen is present, then it activates this prolyl hydroxylase enzyme, which ultimately causes the hydroxylation of prolyl. So you can see as you go down this cascade on the left-hand side of the slide, the presence of oxygen causes the prolyl groups on HIF alpha subunits to change to a hydroxylated form. This changes the conformation of the molecule so it is recognized by a variety of additional enzymes and proteins, which ultimately degrade the HIF alpha subunit. And this includes von Hippel-Lindau protein as well as ubiquitin. And ultimately, this complex is degraded by the proteasome within the cytoplasm. In the presence of hypoxia, however, these prolyl hydroxylase enzymes are not activated, and HIF alpha subunits, in this slide you can see we're talking about HIF alpha 1 and HIF alpha 2, because they both are involved in erythropoiesis, will migrate to the nucleus, where, as we said, they dimerize with HIF beta, which is ubiquitous and always present, and this heterodimer leads to the transcription of a variety of genes that are involved in red blood cell production. And these transcripts include EPO, the EPO receptor, dimetyl transporter 1 and duodenyl cytochrome B, which augment intestinal iron absorption, transferrin, which is the iron carrier protein in the blood, and the transferrin receptor, which is located in a variety of tissues, but more importantly, is located in the bone marrow so that iron is easily delivered to the red cell precursors, leading to production of hemoglobin. So ultimately, under hypoxia, the hydroxylation of these alpha subunits is inhibited. This stabilizes the alpha subunits so that they can migrate to the nucleus, heterodimerize with HIF beta, and this heterodimer ultimately leads to gene transcription that ultimately increases red blood cell production. So as we said in the previous slide, these genes include a variety of factors: EPO receptor, dimetyl transporter, duodenyl cytochrome B, transferrin receptor. And as you can see in this diagram, this also contributes to the red cell production through a variety of mechanisms. EPO is increased because of the gene transcription. Transferrin is increased, which increases transport of iron to the bone marrow. Hepcidin is downregulated through an indirect effect by increased erythropoiesis that also increases iron mobilization. And in the duodenum, the increase in the transcription of dimetyl transporter 1 and duodenyl cytochrome B lead to iron absorption, which further augments iron delivery to the bone marrow and helps to contribute to erythropoiesis. So there is a new drug class, which are called HIF prolyl hydroxylase inhibitors. And basically what these do is mimic the hypoxic state by inhibiting the action of prolyl hydroxylase and allowing for HIF alpha to survive, ultimately migrate to the nucleus, and heterodimerize with HIF beta to produce the transcription of the genes that we previously mentioned. So ultimately, this leads to the stimulation of erythropoiesis, improvement in iron absorption, improvement in iron mobilization, and indirectly decreases hepcidin levels. there are 6 drugs in the HIF-PHI class that are in various stages of clinical trials around the world. And these include roxadustat, vadadustat, daprodustat, molidustat, anirodustat, and dizidustat. Only 3 of these drugs, roxadustat, vadadustat, and daprodustat, have undergone the large-scale global clinical trials that are of sufficient statistical robustness and duration to assess long-term complications to allow them to be evaluated by the Food and Drug Administration in the United States. So the key takeaways from this section are that hypoxia-inducible factors, or HIF, are oxygen-sensitive proteins that regulate the cell's transcriptional response to hypoxia. The heterodimeric complex of HIF-alpha and HIF-beta is regulated by this group of oxygen and iron-dependent prolyl hydroxylase domain enzymes. And inhibition of these prolyl hydroxylase domain enzymes by a new class of drugs called HIF-PHIs creates a pseudo-hypoxic environment within the cell, which leads to the preservation of HIF-alpha, preventing its degradation. And this ultimately stimulates the transcription of the erythropoietin gene through a variety of mechanisms, improves iron absorption and its mobilization, indirectly reduces hepcidin levels, and ultimately augments erythropoiesis.
Thank you, Dr. Wish. That was just a wonderful, concise, and eloquent presentation. I'm going to invite you and Dr. Lerma to join for the panel discussion. So let me kick this off, Dr. Wish, by asking you about HIF-PHIs. You've written quite extensively about the pros and cons of HIF-PHI therapy. Please provide us with an update of what you see as the current unmet need in anemia management and how you feel HIF-PHIs might fill this need.
Well, which I didn't mention, and obviously it's an important meeting of an unmet need, as you mentioned, Dr. Singh, is the fact that the HIF-PHI class of drugs is orally administered. They are small molecules, and they are delivered through the oral route, so that makes them much more user-friendly for the patient than ESAs that have to be delivered by parenteral administration. So as Dr. Lerma so eloquently pointed out in his previous presentation, there is a major gap in terms of the number and percentage of patients with CKD-associated anemia and our effectiveness in delivering the drugs that they need, currently ESAs, to treat the anemia, leading to perhaps adverse long-term consequences. So the ease of administration of the oral administered HIF-PHIs meets a major unmet need. Now, the other unmet need is the fact that many patients, perhaps as Dr. Lerma said, 6 to 10% receiving ESA therapy are ESA resistant. And because the HIF-PHIs downregulate hepcidin, and it's thought that much of the ESA resistance that we see is due to hepcidin from chronic inflammation, the HIF-PHIs have the potential to effectively treat anemia in patients who are ESA hyporesponsive.
Great, thank you. Dr. Lerma, you presented a lot of very interesting data about the prevalence and gaps. Translating the evidence you presented to what you see in clinical practice, do you see patients coming to you who should be treated that are not being treated, either patients who are not on dialysis or those patients who are starting dialysis? Is there a gap in terms of access to ESAs that you see in your clinical practice?
In practicality, in the past, what I used to do is that we used to have an infusion center in our office, but this is not something that is readily available in all clinical practices. It's inconvenient, it's a burden for the patient, for the caregiver, so on and so forth. So I think administering it by the oral route is certainly provides a distinct advantage in these patients who would necessarily be treated. Most often than not, what I see is there are some smaller practices wherein they don't have access to an infusion center, and so they just don't get these patients treated, unfortunately.
And Dr. Wish, we all have the benefit in some ways of living in and working in urban centers. But what about the rural landscape? I mean, there aren't necessarily infusion centers or health systems that are half an hour drive away from someone's home. There are home therapy patients on PD and others who might benefit, even if conventional ESAs are available. It's just difficult to get them. What are your thoughts on that?
Well, I think you point out a very good point, Dr. Singh, that the distance that many of these patients have to travel can be a major barrier to their receiving ESAs, either as non-dialysis CKD patients or as home dialysis patients. And as you're all aware, there's a concerted effort on the part of Medicare and other payers to increase the percentage of home dialysis patients. So if, as Medicare hopes and the Advancing Kidney Health Initiative targets, some 40 to 50% of ESRD patients are going to be on home dialysis, then the relative lack of access to ESAs can be a major barrier to the effective treatment of their anemia in patients who are in rural areas that have to travel long distances to an infusion center.
Great, thank you. We've now reached the end of our allotted time for today. I'd like to thank Dr. Wish for a great presentation. Also, we'd like to thank GSK for their support of this program. We'd like to ask the learners to please follow the link that is provided at the end of the program to fill out the evaluation and post-test in order to receive the CME credit. This provides us with valuable input that can be used for planning of an upcoming program. This is part 2 of a 4-part series. There will be 2 additional social media broadcasts scheduled for September 28th and October 5th, 2022 at 2:30 p.m. Eastern Daylight Time. Join us as we explore emerging agents targeting HIF and patient-centered care in the new era. Please follow the Iridium CE social media Twitter or Facebook page so you will be sure not to miss updates. Thank you again for joining us.